Margie here. Today we're diving into a surprising connection that you may not even know about: osteoporosis and heart disease. These two conditions share many of the same root causes, and understanding the link can be life-changing. So in this episode, you'll discover number one, how your bone health and heart health are connected. Number two, the role of vitamin K2 in keeping your bones strong and your arteries clear. Number three, why high blood pressure and blood sugar issues can weaken your bones. Number four, the tests that can predict your risk of a heart attack and why it matters for your bones also. And number five, simple lifestyle changes that can protect both your heart and your bones for years to come. And I'm excited about our special guest, Dr. Kim Millman. And Dr. Millman is a Stanford, UCSF, and USC trained functional medicine physician and research scientist with over 30 years of experience. She's been specializing in osteoporosis for more than 16 years, and together we co-teach Restore and Rebuild, 100 Days to Healthier Bones. And Dr. Millman and I have also created the Integrative Bone Health Practitioner Certification course that'll be starting in October. And she's just an absolute wealth of information. So today, what I wanted to share is what Dr. Millman had done. It was a program that she presented at my last summit, and I'd gotten so many compliments on it. And recently, a lot of people have been asking me about cardiovascular issues and the relationship with osteoporosis. And so I thought, you know what? Why don't I share this with my podcast community? So it's full of lots of great information. And don't worry about understanding everything, because you can listen to it again and again. But it's just, just something that we don't think about. But yet there's so much that we can do for both our bones and our heart health. So lots of great information. Stay tuned.
Welcome to the Heart Health for Unbreakable Bones Masterclass. Many of us realize that in the U.S., heart disease is the #1 killer of men and women, and that osteoporosis is the #1 metabolic disease. However, most of us do not appreciate how intricately intertwined heart and bone health are. We'll start off by giving you a basic understanding of cardiovascular disease and some of the terms you need to know. Your circulatory system, or your vasculature, is the conduit that blood and oxygen flows through to feed the heart and the rest of your body. Your vascular system consists of arteries, veins, and lymphatics. When the arteries become blocked, it reduces the blood flow and the oxygen to those tissues. The arteries that feed the heart, or the coronary arteries, can become blocked, and when this happens, this is called coronary artery disease, and it can lead to heart attacks. When the arteries that feed the brain are blocked, this is called cerebrovascular disease, and this can cause strokes. A blood vessel in your vasculature consists of a one-cell wall thick endothelial lining that you can see right here, with a protective barrier with frond-like projections called the glycocalyx. And this is a micro-thin, gel-like layer that coats the entire surface of the endothelial wall. The glycocalyx is a very important component of your circulatory system. It physically blocks inflammatory cells of the immune system, like monocytes and platelets, that can cause clots and LDL cholesterol from infiltrating the endothelial wall and forming plaques. It aids in the production of nitric oxide that is a vasodilator, which helps to keep your arteries elastic. The glycocalyx is an antioxidant, an anticoagulant, anti-adhesive, and anti-inflammatory structure. Plaque in an artery can reduce the blood flow and oxygen to the tissue by rupturing into the lumen and blocking flow. When this happens, this is termed atherosclerosis. Plaque is initiated by oxidation and inflammation. LDL cholesterol becomes oxidized, and inflammatory immune cells like monocytes begin the process by invading a glycocalyx, which is degraded, as you can see in the diagram here. The particles pass through the vulnerable endothelial membrane. This causes thickening of the membrane and also calcium accumulation. The plaque becomes vulnerable when the monocytes turn into macrophages that engulf the LDL and form a macrophage LDL complex. These complexes fuse together and begin to die, leaving what's called a lipid-rich necrotic core. As the core grows, it becomes unstable and it ruptures into the lumen of the blood vessel. Platelets accumulate around the ruptured, unstable plaque and form a clot. The unstable plaque and the clot occludes the lumen, and this reduces the blood flow into the tissue and causes tissue damage. And when this occurs in the heart, it causes heart attacks. The glycocalyx is a delicate structure and can easily be damaged. Many of the known cardiovascular risk factors damage the glycocalyx, which can then lead to vascular permeability or leaky blood vessels that is very similar to a leaky gut. The factors that break down the glycocalyx are many of the same factors that increase bone breakdown. These factors include elevated blood glucose, oxidative stress, increased inflammatory burden, hypertension, obesity, increased ratio of oxidized LDL to protective HDL, smoking, lack of exercise, stress, toxins, and high homocysteine. Because plaques accumulate calcium and calcify, one way to quantitatively measure the plaque burden in the coronary arteries is with a coronary artery calcium scan. This is a very quick CT scan that measures how much calcium is deposited in the arteries that feed the heart or the coronary arteries. What we found in the MESA study, or the multi-ethnic study of atherosclerosis, was that the coronary artery calcium scan was the most powerful predictor of atherosclerotic cardiovascular disease risk. The MESA study was a large study that measured cardiac events over 3 to 5 years and correlated the events to the coronary artery calcium score. Coronary artery calcium scores of 0 had an event rate of 0.4%, which was very low. Coronary artery calcium scores from in between 100 to 400 had an event rate of 4.3%. Coronary artery calcium scores from 400 to 1,000 had an event rate of 7.2%, and coronary artery calcium scores above 1,000 had an event rate of 10%. So as the coronary artery calcium scores increased, so did the event rate. The authors concluded that no conventional risk factor has shown to have as much predictive power as the coronary artery calcium score. I recommend a coronary artery calcium score CT to almost all my patients for them to help stratify their cardiovascular risk. Just like plaque in your arteries, a lack of nitric oxide is another reason that your circulatory system can be less effective at carrying oxygen and nutrients to the tissues. Nitric oxide is a molecule that's primary role is a vasodilator. Nitric oxide helps keep the arteries elastic. When the arteries become stiff, this can lead to hypertension and increase your risk of cardiovascular disease and events including heart attacks and strokes. Nitric oxide is also an antioxidant, anti-inflammatory, and is involved in having a healthy immune system. With a lack of nitric oxide, the small arteries first become stiff, and almost all people with small, stiff arteries have hypertension. And then when the larger arteries become stiff, cardiovascular disease and events dramatically go up. Almost everyone over 40 years old has low levels of nitric oxide. We make nitric oxide from our diet, but to have good levels, you would need at least to be eating 10 servings of fruits and vegetables per day, including dark green leafy vegetables like kale and arugula and spinach, as well as beets and grapes. When we are over 40 years old, our ability to make nitric oxide from our diet decreases dramatically. Also, many things interfere with our ability to make nitric oxide, including mouthwash, proton pump inhibitor, acid reducers, and H2 blocker acid reducers, having a bad microbiome in your mouth or in your gut, and if you don't make enough gastric acid.
Hey, Margie here. As a physical therapist, I know firsthand how important exercise is for our bones, overall health, and happiness. And unfortunately, there's a lot of confusion on what exercises are safe and effective for people with osteoporosis. That's why I created this handout that contains a 30-minute video where I explain the concepts so you understand the do's and don'ts when it comes to exercise. And this is important because this way you can go into any class and know what you should be doing and what you should avoid. Because too many people are doing exercises that actually increase their risk of spinal fractures. I also included videos of me demonstrating effective balance, posture, and weight-bearing exercises you can put into your day right away. So all you need to do to access this handout, it's free, is go to tinyurl.com/osteoporosis exercises. So it's tinyurl.com, again, /osteoporosis exercises, or you can click the link in the show notes. Now back to the show.
While it's obvious that if your circulation is impaired, your bones won't get the nutrients, oxygen, and positive growth signals they need to properly rebuild, we also need to understand that the crosstalk between your cardiovascular system and your bones is extensive and highly regulated. Your circulatory system is a bidirectional conduit for nutrients, hormones, and other metabolic factors. This conduit allows for deposits and withdrawals of nutrients and minerals to and from the body and the bones. Vessel and bone-derived cells and hormonal regulators affect skeletal and vascular health in profoundly interdependent ways. Many of the immune cells, signaling molecules, and hormones involved in heart and bone metabolism talk through shared mechanisms. The evidence of this extensive crosstalk plays out when you look at the extensive links between osteoporosis and cardiovascular disease. In fact, people with low bone mineral density are at an increased risk of having coronary artery disease, coronary vascular events like heart attacks and strokes, and subclinical cardiovascular disease. And this would include evidence of plaque and arterial stiffness. They also have increased rates of cardiovascular mortality. Many traditional risk factors for cardiovascular disease are the same ones that predispose people to develop osteoporosis. Mechanistically, low BMD and atherosclerosis are similar, and many treatments for cardiovascular disease may positively affect the bone. It is very important for you to appreciate this intersection so you can fully understand your risk factors for bone loss. Coronary artery calcium scores over 0 represent some degree of plaque burden. In the MESA prospective study, a coronary artery calcium score over 0 was 36% in the normal BMD group, 49% in the osteopenia group, and 68% in the osteoporosis group when they were evaluating the thoracic spine BMD. In the same study, men and women with osteoporosis were 1.4 times more likely to have a coronary artery calcium score over 0 than those without osteoporosis at the thoracic spine. So this is showing that as your levels of bone mineral density decrease, your likelihood for having plaque in your arteries increase. The Moore trial was looking at bone loss and the risk for cardiovascular events. This was in a trial of U.S. postmenopausal women. When looking at the overall bone mineral density, a person with osteoporosis had a 3.9-fold increased risk of a cardiac event compared to a woman with osteopenia. When just evaluating the BMD at the hip, a woman with osteoporosis versus a woman with osteopenia had a 2.1-fold increased risk of having a cardiovascular event. And when looking at a woman who had at least one vertebral fracture versus a woman who had none, there was a 3-fold increased risk of a cardiac event. There is also growing evidence that bone loss increases the risk of dying from heart disease. In the study of osteoporotic fractures, they showed that for each standard deviation decrease in the bone mineral density at the hip, these people had a 1.3 times increased risk for coronary heart disease mortality among white women 65 years and older. And in a study among Danish women, for each standard deviation decrease in forearm bone mineral density, the risk of cardiovascular mortality increased more than twofold. In a study among postmenopausal women, a vertebral compression fracture was associated with a 2 times increased risk of cardiovascular mortality, and in 65 to 75-year-old British men, for each standard deviation decrease in total hip BMD, there was a 32% increased risk for cardiovascular disease mortality. So this is showing that decreased bone mineral density in various populations increase the risk of death when it came to coronary events. The crosstalk between bone and cardiac metabolism works through the intersection of many metabolic processes. This includes low sex hormones, inflammation and oxidative stress, leaky gut, vitamin D and vitamin K deficiencies, insulin resistance and diabetes, hypertension, and lipid abnormalities, and these are just a few. Both low estrogen and low testosterone are significant risk factors for bone loss and for cardiovascular disease. We already know that low estradiol is one of the main risk factors for lower BMD in a postmenopausal woman, but how does lower estradiol affect a woman's cardiovascular health? We know that during the 5 to 6 years around the final menstrual period of a woman in the menopause transition period, not only does a woman see dramatic changes in her hormones, including a significant decline in estradiol, but she also sees alterations in her body composition, lipids, and other measures of her vascular health. Menopausal symptoms are associated with increased risk of cardiovascular disease. Vasomotor symptoms or hot flashes are associated with worsening cardiovascular risk factors, including adverse lipids, insulin resistance, a greater risk for hypertension, and subclinical atherosclerosis, as in plaque accumulation and arterial stiffness. Poor sleep quality raises the risk of metabolic syndrome and carotid plaque. Having more than or equal to 3 depressive episodes versus no episodes is associated with elevated coronary artery calcification scores. And among postmenopausal women enrolled in the WHI trials, depression was an independent predictor of cardiovascular death and all-cause mortality. As estradiol decreases, cardiovascular risk factors increase. Worsening adverse lipid profiles, including total and LDL cholesterol, metabolic syndrome, and vascular remodeling at midlife, is driven by the menopause transition more than chronologic aging. What I mean by this is that lower estradiol affects these factors more than age itself. In the period 2 years before and 2 years after the final menstrual period, a woman will typically see more dramatic changes in body composition, including more fat mass, loss of lean muscle mass, and accumulation of visceral adipose tissue than in any other time in her life. Metabolic syndrome increases with menopause. Cardiovascular remodeling increases at menopause. We see this as an increase in carotid intimal medial thickness and carotid adventitial diameter. Both surrogate markers for plaque are found during the late perimenopause. And there's a significant increase in arterial stiffness, which occurs within 1 year of the final menstrual period. Arterial stiffness is associated with high blood pressure and more cardiac events like heart attacks and heart failure. For a man, testosterone deficiency is a major risk factor for bone loss, and it is also a major risk factor for cardiovascular disease. Testosterone deficiency, which has historically been defined as a total testosterone less than 300 nanograms per deciliter, leads to endothelial dysfunction and increases arterial stiffness. It decreases nitric oxide production. Testosterone deficiency decreases cells involved in endothelial repair. It increases inflammation, and it causes accelerated vascular aging in part due to oxidative stress and inflammation. There was a 5-year prospective study of Italian men with erectile dysfunction where they evaluated cardiovascular risk factors and total testosterone levels. Men with total testosterone less than 300 nanograms per deciliter, which is considered testosterone deficiency, had a higher risk of traditional cardiovascular risk factors, including hypertension, diabetes, dyslipidemia, obesity, and endothelial dysfunction score, as well as cardiovascular events, including heart attack, death after heart attack, major stroke, and all major adverse cardiovascular events. Only dyslipidemia, obesity, and total testosterone less than 300 and erectile dysfunction were independent predictors of cardiovascular events. After your bones, your vasculature is the second most calcified structure in your body. Calcification in the arteries causes arterial stiffness, which leads to hypertension and cardiac events, while calcification of the bones leads to denser, stronger bones. Calcification in the arteries is mechanistically very similar to mineralization of the bones, and the minerals deposited in the arteries are very similar to the hydroxyapatite crystals that are deposited in the bones. Oxidation and inflammation in the body regulates these processes. When your cholesterol oxidizes, this promotes smooth muscle cells in the arteries to differentiate into osteoblasts and increases calcification in the vasculature, which is not good. At the same time, it inhibits bone growth. Dysbiosis causes systemic inflammation and bone breakdown. It also has been linked to heart disease. A measure of dysbiosis is an increased ratio of Firmicutes to Bacteroidetes with decreased amounts of bifidobacteria and lactobacilli. A dysbiotic microbiome was found to decrease the amount of cholesterol eliminated in the stool, which increased blood LDL cholesterol. This was in part due to the decreased production of short-chain fatty acids produced by good bacteria. A leaky gut or increased intestinal permeability allows the lipopolysaccharides from the dysbiotic gut bacteria to cross the gut membrane. And the lipopolysaccharides, if you remember, are the outer wall of the dysbiotic gut bacteria. This leads to cholesterol accumulation and depositing in the arteries, chronic low-grade systemic inflammation, and progression to metabolic syndrome and atherosclerosis. Dysbiotic gut bacterial consumption of phosphatidylcholine and L-carnitine and choline from a high animal protein diet can result in trimethylamine, which is then converted to trimethyl N-oxide, which is TMAO in the liver. TMAO is an interesting marker in the blood that represents both dysbiosis and plaque accumulation, plaque vulnerability, and increased cardiovascular events. Increased TMAO has been associated with higher risks of clotting, atherosclerosis, and incidence of major adverse cardiovascular events, which include heart attack, stroke, or death, and linked to plaque vulnerability. For every 10 micromole per liter increase in TMAO, there's been a 7.6% increase in relative risk of cardiovascular mortality. This diagram illustrates how your gut microbiome can contribute to cardiovascular disease. So a dysbiotic microbiome with an increased Firmicutes to Bacteroidetes ratio with decreased bifidobacterium and lactobacillus combined with a Western ketogenic diet high in choline and carnitine can get converted in the liver to trimethylamine N-oxide, which is TMAO. And then a permeable leaky gut can allow lipopolysaccharides from the outer membrane of the dysbiotic bacteria to translocate across the gut membrane. And also there would be decreased production of short-chain fatty acids because of the decreased amount of short-chain fatty acid producing bacteria in the gut lumen. This can cause systemic endotoxemia, inflammation, and progress to metabolic syndrome. While on the other hand, if there's eubiosis, which means that the microbiome has plenty of bifidobacterium and lactobacilli, and you have a decreased ratio of Firmicutes to Bacteroides, you have a good microbiome. And then in the absence of a lot of choline and carnitine for fuel for producing TMAO does not get produced. You have a lot of short-chain fatty acids being produced by these bacteria. You have no translocation across the membrane, and you have an anti-inflammatory process that helps to dampen risk factors to cardiovascular disease. We know that vitamin D is intricately involved in mineral metabolism and vital to having strong, resilient bones, but also may provide many functions that protect your cardiovascular system. Vitamin D deficiency has been associated with increased cardiovascular disease, seen in the Framingham Offspring study, increased cardiovascular risk factors, increased risk for hypertension, increased risk for cardiovascular morbidity and mortality, and all-cause death. Vitamin K has a crucial role in regulating the calcification of the bone and the vasculature. Osteocalcin is a protein that, when activated, mineralizes bones, and matrix GLA protein, when activated, blocks the mineralization of the soft tissues, including the arteries. Activation of both osteocalcin and matrix GLA protein depends on vitamin K through a reaction called carboxylation. In the bones, carboxylated osteocalcin regulates the hydroxyapatite size and is crucial for hydroxyapatite crystals to align properly to the collagen fibers to promote bone mineralization. In the soft tissues, matrix GLA protein is made in the vascular smooth muscle cells and protects the arteries and cartilage against mineralization. So this diagram shows you that in the vascular smooth muscle cells, you have matrix GLA protein that is inactive. And as it becomes carboxylated, it becomes active and it prevents vascular calcification. While on the other hand, osteocalcin in the osteoblast, when it's carboxylated, it becomes activated and it helps mineralization in the bone and bone formation. And this carboxylation of matrix GLA protein and osteocalcin is vitamin K dependent. Because vitamin K is a regulator in the calcification in the bones and the vasculature, vitamin K deficiency has been suggested as a common denominator for atherosclerotic calcification and low bone mass. Because of this, there have been many studies investigating whether vitamin K supplementation prevents or reverses calcified plaque in the arteries. There were 3 meta-analyses evaluating whether vitamin K supplementation reverses or prevents vascular calcification or reduces arterial stiffness. 2 meta-analyses were done on chronic kidney disease patients and 1 on a combination of chronic kidney disease patients and a healthy population. In 1 out of the 3 meta-analyses, vitamin K mildly improved vascular and elasticity, while of course, in 2 out of the 3 studies, it did not. And in only 1 out of the 3 studies did vitamin K slow down the progression of the coronary artery calcium score, which is a surrogate marker for plaque in the arteries. And again, 2 out of the 3 studies did not show that vitamin K slowed down the progression or reversed coronary artery calcium scores. So these meta-analyses did not consistently show either slowing down the progression of plaque or improving vascular elasticity, and that is a key component in heart disease with vitamin K supplementation. So we need to keep in mind that in all 3 of these meta-analyses, there was a population that was studied that had chronic kidney disease, and there may be some additional processes that are going on in chronic kidney disease patients that would not be present in a healthy population. Also, that the studies pooled in the meta-analyses, they studied vitamin K1 with doses from anywhere from 500 micrograms to 10 milligrams per day, and vitamin K2, MK7, was studied in doses from 90 micrograms to 400 micrograms per day. So these doses varied dramatically, and it's hard to say if part of the issue could have been the difference in doses that was contributing to the lack of evidence that was found. There were some additional major studies that did not involve people with chronic kidney disease, which represents a population that would be more representative for people with bone loss. And we also saw some inconsistencies in that evidence as well. One study was done in men with no heart disease, and they found no difference in coronary artery calcium score, again, a surrogate marker for plaque, 720 micrograms per day of MK7. But when they subdivided the men into pretty high coronary artery calcium scores, which was greater than 400, compared to men with coronary artery calcium scores of 400 or less, they did show that vitamin K slowed down the coronary artery calcium progression. And interestingly, in this group, they found that the safety events were fewer with supplementation, and that was 1.9% in the supplemented group compared to 6.7% in the non-supplemented group. And these events actually included heart attacks, coronary revascularization, and all-cause mortality. In a study among people with diabetes, newly calcified plaque was reduced significantly. And in this study, they used some advanced imaging, and it shows the very beginnings of plaque initiation. So it may have been that this was more sensitive at picking up early plaque. And in this study, they evaluated 10 milligrams of vitamin K1. In another study among postmenopausal women using 180 micrograms per day of MK7, they saw improved arterial stiffness, especially in those women who had the highest levels of arterial stiffness to begin with. And that means better elasticity in the arteries, which could translate into improved blood pressure and less cardiac events. And lastly, in healthy older adults, they looked at 500 micrograms of vitamin K1 per day and found no difference in the progression of coronary artery calcium unless they analyzed those who took treatment at least 85% of the time. And for those people who had adhered to treatment and had had a coronary calcium scan of at least over 10, which is very mild disease at baseline, had a 6% decreased progression of coronary artery calcium score with vitamin K1. And in all the studies, vitamin K status improved with vitamin K supplementation. And in this cases, they were measuring decarboxylated matrix GLA protein as a marker for vitamin K deficiency. Unfortunately, there is insufficient evidence that vitamin K supplementation slows down or reverses vascular calcification or decreases arterial stiffness. But as this presentation goes over, the links between bone and heart health go so far beyond vitamin K. So it is very likely that there's a multifactorial issue going on, and that may be one of the reasons why we're not seeing conclusive evidence that vitamin K prevents or reverses calcified plaque. However, mechanistically, it is clear that having sufficient vitamin K is crucial to protecting your arteries from calcification, leading to stiffness, hypertension, and cardiac events, as well as preventing bone fractures. The use of higher dose vitamin K supplementation has raised concerns of possible increased risk of clotting. In these studies, different doses, including relatively high doses of vitamin K1 and K2, MK7 supplementation were used. In all studies evaluated, there were no adverse events attributable to the supplementation. This included deep vein thromboses, stroke, heart attacks, coronary revascularization, and cardiac mortality. Vitamin K supplementation, even at high dose, is safe and it's not associated with an increased risk of clotting. Given the fact that vitamin K regulates the crosstalk between the bone matrix and your vasculature, it is clear that your vitamin K status is important for both the health of your heart and your bones. However, at this point, the data is inconclusive as to whether vitamin K supplementation slows down or reverses vascular calcifications or improves vascular elasticity. It is likely that there are other non-vitamin K related factors involved, and these studies have only used vitamin K1 or vitamin K2 at a large range of doses. So based on the evidence that we have at this point, my recommendation for both cardiac and bone health vitamin K supplementation is to take a mixture of vitamin K1, and I would say 1 milligram per day, and vitamin K2, MK4, 5 to 15 milligrams twice per day, and MK7 at 180 micrograms per day. That way you have all the study data covered, whereas some studies were done with K1, some studies were done with K7, and really good fracture prevention data exists for MK4. But one thing is certain, vitamin K supplementation is safe with no risk of increased clotting at the doses studied. And of course, these recommendations are not for people with known clotting disorders or for those who are on a vitamin K antagonist blood thinner. We know that even prediabetes increases the risk of fractures, and blood sugar dysregulation is a well-known cardiometabolic risk factor. Advanced glycation end products, or AGEs, are sugar molecules that attach to various proteins in the body and cause them to be dysfunctional. AGEs are largely responsible for how we age, and in the vasculature, AGEs cause endothelial dysfunction, increase vascular stiffness, result in oxidative damage, and increase the risk for hypertension. AGEs reduce bone microcirculation, cause osteoblasts to turn to fat, reduce bone turnover, thins the bone cortex, impairs collagen cross-linking, and decreases bone strength. Hypertension lowers bone mineral density and increases fracture risk. Hypertension increased the incidence of hip fracture in U.S. women by 49%. In a meta-analysis of more than 1.4 million people, osteoporotic fractures were 33% higher among those with hypertension than those without, and that was true for populations in Asia and in Europe. While it is clear that abnormal lipids are a risk factor for coronary vascular disease, it is less known that abnormal lipids can contribute to bone loss. Dyslipidemia has been associated with lipids depositing in the bone vascular system and the bone marrow, which reduces blood flow and oxygen to the bone. Low bone marrow density and reduced bone stem cells, inhibiting osteoblasts and stimulating osteoclasts, and low HDL causes chronic inflammation in the bone, promoting resorption. Low bone mineral density has been associated with low HDL and high LDL, and statin use has been related to higher BMD and reduced fracture risk. Additional links between bone loss and heart disease include a diet that is high in salt, refined carbohydrates, sugars, starches, trans fatty acids, and some but not all saturated fatty acids, smoking, lack of exercise, parathyroid hormone, homocysteine, and excess alcohol. You can see that the bone vascular axis consists of crosstalk between the two, with many shared processes influencing one another in a complicated way. Osteotrophic hormones and nutrient cofactors regulate both the vascular and the skeletal mineralization. Cellular, endocrine, and metabolic signals flow bidirectionally between the vasculature and the bone that are necessary for optimal bone and cardiovascular health. They are so intricately intertwined that I call them the osteocardiometabolic system. I'd like to conclude by telling you about two very powerful nutraceuticals that may help support your cardiovascular system. The first nutraceutical is arterosil, which has been shown to help repair and keep the glycocalyx strong. The key component in arterosil is rhamnant sulfate, which comes from the green algae Monostronum nitidum, and a powerful blend of antioxidants and polyphenols from 22 fruits and vegetables that are known to improve endothelial function and reduce the risk of cardiovascular disease. Rhamnant sulfate is a powerful glycocalyx regenerating compound. It decreases the permeability of the glycocalyx to water and to LDL, and this has the potential to improve leaky blood vessels and improve arterial elasticity. Importantly, rhamnant sulfate also may help reduce cardiovascular risk factors that drive the degradation of the glycocalyx and cardiovascular disease itself. Rhamnant sulfate supports healthy blood sugar when we know that elevated blood sugar for even 15 to 20 minutes can damage the glycocalyx. It can help with weight control and decreasing LDL cholesterol, including LDL particle number and the amount of oxidized LDL. And based on a study with 10 adults who had uncontrolled blood pressure, after giving them arterosil for 3 months, they found significant decreases in diastolic blood pressure, and they found that it supports healthy inflammation levels in the endothelial cell lining, helps platelets not to stick together to form clots, and it has antiviral properties and anti-tumor activities. In a human proof of concept study, arterosil reduced vulnerable plaque. The study evaluated arterosil's effect on vulnerable plaque in the carotid arteries, defined as plaque with a lipid-rich necrotic core, which is soft and prone to rupture. This was determined by a highly sensitive MRI plaque view test. After giving participants arterosil 1 twice daily for 60 days, they found a significant carotid plaque regression, 47% in men and 64% in women. In another study evaluating arterosil, there were 6 patients at high risk for cardiovascular events with a significant presence of plaque in their carotid arteries as defined by an increased CIMT, or carotid intimal media thickness, of greater than 1 millimeter. This is an ultrasound evaluation of the arterial wall thickness, and if it's high, it implies plaque accumulation. Each of these participants fit the profile of having stubborn plaque, and this was when they did not improve with usual pharmaceuticals, dietary supplements, and lifestyle modifications. Participants took arterosil 1 twice daily for 6 months. Plaque volume was measured at the beginning and end of the 6 months. Amazingly, the mean total plaque burden was 8.42 millimeter in the beginning, and at the end, it was significantly lower at 2.87 millimeter, with an average reduction of 5.55 millimeters. Arterosil has recently been patented for vulnerable plaque stabilization and regression. I often recommend arterosil to my patients to help establish a healthy glycocalyx and endothelial function. There are no contraindications. It is safe for people on blood thinners, cholesterol-lowering medications, and blood pressure medications. The dose is 1 tablet twice a day. However, for people who have diabetes, insulin resistance, claudication, which would be pain in the legs because of poor circulation, chest pain, or erectile dysfunction, I give a loading dose, which would be 2 tablets twice a day for a few months, and then dose down to maintenance, which is 1 tablet twice a day. Another powerful nutraceutical that improves nitric oxide and supports cardiovascular health is called Vascanox. In a 2023 study, mild hypertensive patients were given 2 caps in the morning of Vascanox for 4 weeks. They saw an immediate increase in nitric oxide measured with salivary strips. They saw immediate reductions in blood pressure, both systolic blood pressure between 10 and 11 millimeters per mercury, and diastolic blood pressure with the same kind of results, 10 to 11 millimeters of mercury. The reduction in blood pressure was similar to single drug therapy. The higher the blood pressure was at the start of the study, the better the reduction was at the end of the study. And if someone had normal blood pressure, they didn't see much of a change in blood pressure, and no one's blood pressure dropped too low. There were no side effects, and there were no drug interactions and no contraindications. Berkeley Life nitric oxide saliva test strips indicate salivary nitrite levels, which are a precursor to nitric oxide. And in just seconds, you can test your salivary nitrate and determine your level. You can measure the response of your body to taking Vascanox by testing it at baseline and 2 hours and 4 hours after testing it. This is my own salivary testing strip. So at the beginning, my nitric oxide level was very low, and 2 hours after Vascanox, it was improving. And after 4 hours after Vascanox, it was improving yet again. Vascanox works by promoting the production of nitric oxide and inhibiting the breakdown of nitric oxide with components of garlic extract. Peak nitric oxide level was 4 times higher than other products that promote nitric oxide, and higher levels lasted 24 hours compared to other products lasting 4 hours. I often recommend Vascanox to my patients for healthy nitric oxide support and to help with healthy blood pressure levels. Blood pressure reduction was immediate, but could take up to 4 months for Vascanox to help improve elasticity of large arteries. The dose that I use is to take 2 capsules in the morning. I hope that this presentation has helped you to understand the intricate links between the cardiovascular system and your bone metabolism, and how imperative it is for you to understand your cardiovascular risk profile so that you can prevent yourself from having cardiovascular disease, and also that you understand fully your risk factors for bone loss and you can have strong, resilient bones.
I hope you enjoyed Dr. Millman's presentation and have a better understanding of the connection between your bones and heart health and what steps you can take so that you have healthy bones and a healthy heart. I wanted to mention that Dr. Millman's course that I co-teach, Restore and Rebuild 100 Days to Healthier Bones, is starting shortly, and there's still time to enroll. The information for that will be in the show notes, but make sure to use coupon code HAPPYBONESF25 to save $100. And also, Dr. Millman and I, as I mentioned earlier, are starting a certified integrative bone health practitioner training for health practitioners who want to bring this bone health knowledge to their clients. And so we're going to be hosting a free webinar on August 25th at 4:00 p.m. Eastern Time. And that's for practitioners, and we're going to be talking about bone testing for osteoporosis. So if you're interested, you can sign up tinyurl.com/osteotesting. And that link will also be in the show notes. So thank you so much for tuning in, and I look forward to seeing you on the next episode.